In this video we're going to talk about ectopic pregnancy, and ectopic pregnancy is best explained with the diagram. Normally when you have a fertilized egg or a zygote, it implants into the uterus, and in particular the endometrial lining of the uterine cavity. This is the uterine cavity inside. So the ovary will release an egg here, and the sperm will travel down the fallopian tube, and where they meet, that's when fertilization occurs, and then eventually the egg will travel back down the fallopian tube and eventually implant into the uterus. Now that happens most of the time, but sometimes it does not happen, as the fertilized egg implants itself in an ectopic location, meaning a location other than normal. And there's several locations, but the most common of which is shown here, being the fallopian tube. There's other locations like cervix or abdominal or pelvic cavity, but by far the most common is the fallopian tube. So why is this a problem? Why is this scenario a problem? The reason is because the fallopian tube doesn't expand the way a uterus does during pregnancy. So eventually the fallopian tube is not big enough to house the growing zygote as it becomes an embryo. So between 6 to 16 weeks there will be a rupture, and then when that happens, that's basically the end of the pregnancy. So this is a very severe problem, and we'll talk about the symptoms and the treatment. First, what I wanted to discuss is, why does this happen? What would be some of the reasons? Well, there's a big long list, but I'll touch on the most important reasons. Here are some of the risk factors. Advanced age, a prior ectopic pregnancy. Another reason that this can happen is a history of pelvic inflammatory disease. And the reason that is because when you have pelvic inflammatory disease, that can result in scar tissue being formed in the fallopian tube. And when the scar tissue forms, it prevents the fertilized egg from traveling down to the normal or correct location. So that's why pelvic inflammatory disease can be a risk factor. The use of an intrauterine device for contraception, multiple sexual partners, and another important risk factor is cigarette smoking, interestingly. And another one is prior induced abortion. Emphasis on the word induced. So not a spontaneous, but induced abortion. So those are some of the reasons. So let's talk about the symptoms. Well, most of the time when when a woman has an ectopic pregnancy, there are no symptoms until the rupture occurs, and the symptoms vary. But if there is a rupture, the symptoms will include pelvic pain. They can include cervical motion tenderness, CMT, adnexal tenderness, cervical motion tenderness is when the finger is moved, when the cervix is moved with the finger on a physical exam. There's tenderness, and adnexal tenderness just means tenderness in the adnexa area of the pelvis. These symptoms are the symptoms of pelvic inflammatory disease. So how do you know if a patient presents, or even on a licensing exam, if you have these things mentioned in the vignette, how do you know that it's pelvic inflammatory disease or ectopic pregnancy? Well, one of the key things that you need to look for is, in ectopic pregnancy, You should suspect an ectopic pregnancy in any female of reproductive age who has these symptoms but also has vaginal bleeding. And another important thing is if she has does not know when her last menstrual period was. So those are the key things to differentiate pelvic inflammatory disease with ectopic pregnancy. So let's say you do have a young or any aged female that is still of reproductive age with those symptoms. How would you go about diagnosing it? Well, there's two main things. The first is a urine pregnancy test, which is known as a beta HCG. And the second test is a pelvic ultrasound. And these two tests are the ones that you would do when you suspect an ectopic pregnancy. This one initially is done with urine, and then if it's positive, they sometimes will repeat the test with the patient's blood. This one, of course, will show you what is going on. So if it is indeed an ectopic pregnancy, there will be nothing in the uterine cavity, but it will show a mass, most likely in the adnexa area, which is here, as it shows in this diagram. So that's what the ultrasound will show. So, how do you treat an ectopic pregnancy? Is there a treatment? Well, there is. There's two main ways. There's surgery, and in particular, we're talking about the resection of the fallopian tube. And that has a special name. It's salpingectomy. Salpingectomy. And what that just means is just a resection of the fallopian tube. You just cut out that portion, assuming the ectopic pregnancy is there. The second thing is with the medication known as methotrexate. Now, methotrexate is only used in certain specific conditions, and I'll explain it. When can you use methotrexate? Methotrexate is usually only used when you have unruptured tubal pregnancy, and in particular, it's got to be pretty small, less than 3 centimeters, and also the beta HCG value needs to be less than 5,000. And if these criteria are met, then you can go ahead and use methotrexate. But there's a very important part of this treatment, and that is the follow-up. How do you know that once you gave the medication that it's actually working? The way you do that is very specific. After you give the drug, on day 4 and on day 7, you have to measure the beta HCG level. And what you're looking for is a decrease of greater than 15%. So I should have wrote greater. So let me just write it out to avoid confusion. Decrease of 15% or more. And if that is indeed the case, when you measure the beta HCG level on days 4 and 7, then you know the methotrexate is working. If it's not, then you have to give a second dose of methotrexate, or you have to proceed to surgery. So now I will discuss a couple clinical vignettes here. An 18-year-old girl comes to the emergency department with her mother because of a 12-hour history of lower abdominal pain and nausea. She is sexually active with 3 different partners, and she usually uses condoms for contraception. She's unsure of the exact date of her last menstrual period. She has never had a sexually transmitted disease in the past. Temperature is 101, blood pressure is 110/70, pulse is 65. Physical exam shows bilateral lower abdominal tenderness, but rebound tenderness and guarding are absent. Pelvic exam shows mild cervical motion tenderness and adnexal tenderness. Small amount of cervical discharge is present. There are no palpable masses. Cervical cultures are taken and sent to pathology for evaluation. The most appropriate next step is, the symptoms are very, very similar or almost identical to pelvic inflammatory disease, PID. But there's one sentence in here that leads you to think of ectopic pregnancy, and that one sentence is right here. She is unsure of her last menstrual period. Now, she may very well have pelvic inflammatory disease, but that one sentence makes you think of ectopic pregnancy. So, when an ectopic pregnancy is suspected, the very first thing you need to do is a urine beta-HCG. And that would be choice C. Alright, next one. 29-year-old female comes to the emergency department where you're working. She is complaining of a 2-day history of nausea and vomiting and some mild left lower quadrant pain. Vital signs are stable. Physical exam shows mild tenderness to palpation in the left lower quadrant. Prior to performing the pelvic exam, the patient informs you that she is menstruating. Exam is significant only for blood in the vault. Routine lab studies are sent and a beta-HCG returns as 2700. You order a pelvic ultrasound, and which identifies nothing in the uterus. However, there is a fetal pole in the left fallopian tube. You inform the patient that she has an ectopic pregnancy and discuss the option of surgery versus methotrexate. The patient decides that she would like to try methotrexate. Appropriate follow-up care for this patient will include, okay, you may remember earlier I talked about methotrexate and that there's certain conditions that you can give it in, and one of them is that the beta-HCG has to be less than 5,000, and that is indeed the case here. So if you give methotrexate, there's a very specific way to follow up, and that is on day 4 and day 7. You have to measure the beta-HCG level, and if the beta-HCG level drops by greater than 15%, then you know that the treatment is working. So, which one of those would that be? Right here. Repeating beta-HCG 2 weeks after diagnosis, if beta-HCG is found to have fallen greater than 15% from day 4 to day 7 of treatment.